Greeting everyone, and welcome to our session today for the Africa Cancer Research and Control Program. Today we are going to be talking about strengthening the cancer workforce in Africa. We are starting at the top of the hour now, and I will just give 1 to 2 minutes for people to join and get settled. And as people do join in, please welcome everybody. We will, this is a 90-minute session. I'm going to just run through some of the session logistics as people are joining and coming into our Zoom platform here. So for every ECHO session, we ask that you please mute your microphone if you are not speaking. If your bandwidth does permit, we welcome you to turn your video on, especially during the discussion period, which will be after our presentations today, which also encourages an interactive environment. But we also understand if bandwidth is limited. We ask that you use the chat function during the meeting. You can use that to please introduce yourselves. So I welcome you to go ahead and do that now. Put your name, institution, what country you're from into the chat. You can also post questions throughout our presentations today in the chat, and also during the discussion, we will welcome you to use the hand raise function to ask questions directly to our esteemed speakers today. There is an option to enable subtitles on your screen. I think if you click on the more dots at the bottom of your Zoom screen, it should pop up as captions. So if that is helpful, please go ahead and do that. And just so you know, the Kenya Network of Cancer Organizations, the ECHO Hub, records our sessions each month, and they post the sessions on the YouTube channel. If you have access to the agenda that Kenko is projecting right now, there's a link to that channel there, and we can share this also after the session. So again, thank you and welcome to our session today. I will go ahead and get started in the interest of time. We have some really interesting presentations to have and want to allow plenty of time for discussion. So formally, I welcome you. My name is Mishka Kolisira. I'm a public health advisor at the Center for Global Health at the U.S. National Cancer Institute and a member of the steering committee for the Africa Cancer Research and Control ECHO program. It's my pleasure to facilitate today's session. Our session title today is Strengthening the Cancer Workforce in Africa. Before I get to introducing our speakers, I just want to give a little bit of background in case you're new to the Africa Cancer ECHO. This is a community of practice that's actually been going since 2018. And we come together to discuss implementation of evidence-based initiatives and interventions all around advancing cancer control in the Africa region. So talking about issues around barriers and also facilitators, what are the research needs, ways to advance the adoption and uptake of locally relevant interventions, speaking at the local, national, and regional level. As I mentioned, there is a YouTube channel where you can access the past recordings. I also mentioned the steering committee. Every year, each of the sessions is convened in partnership with our hub, the Kenya Network of Cancer Organizations, based in Nairobi, Kenya, and a volunteer steering committee that's led by Professor Ntokozo Ndlovu and Dr. Samuel Mbunya. And there is a total of 20, including ex officio members from KENCO as well. Each year, the steering committee conducts a survey of the partners and members of this ECHO and compiles the session topic ideas through that survey. The year for the ECHO is from September through August, and we tailor the curriculum to follow the core elements of national cancer control plans, running from prevention, diagnosis, staging, and screening, treatment, palliative care, and survivorship, and then key overarching areas: service delivery, governance, health workforce, health information systems, research, and finally finance. So today, under the service delivery component, we are covering the cancer workforce. May I please ask you to just mute if you are joining? Thank you. Excellent. So that's a little bit of background about the Africa Cancer Echo. I'm going to go ahead and welcome our speakers for today's session. First, we will have a didactic presentation by Professor Nazik Hamad, who is a professor of medical oncology at St. Michael Hospital in the Department of Medicine in the University of Toronto in Canada. She is going to be speaking on the cancer workforce in Africa, triumphs, threats, and strategies for optimization to improve cancer outcomes. After Dr. Nazik speaks, we will have a case presentation by Dr. Zaimakova, who is a medical oncologist at the Chinhoyi Provincial Hospital and the Ministry of Health and Child Care in Zimbabwe. His talk will be on Zimbabwe workforce needs for National Cancer Control Plan implementation, strengthening the cancer workforce in Africa, a Zimbabwean perspective. After they both speak, we will then have a moderated discussion and Q&A where you can ask your questions and speak further with our esteemed speakers. And as you saw just there on the agenda, you can read more of their more detailed bios there as well. So without further ado, Nazik, I will turn it over to you for your presentation, and welcome.
Thank you so much, Michelle. It's really a pleasure to be here, and I really appreciate all the work that you have done. So here we go. Are my slides clear?
Perfect.
Okay, so for today, for the didactic session, I will be talking about the cancer workforce in Africa. I'll talk about the threats and the triumphs, the progress that has been made, and the strategies to optimize the workforce in order to improve cancer outcomes. I don't have conflict of interest. However, I will be throughout the presentation mentioning some of the work that we have done and published, not to promote myself, but to promote my colleagues who have done a lot of work on the cancer workforce issues in Africa. And so without the workforce, we know there will be no health, there will be no health system, there will be no cancer care, including prevention. And of course, there will be no universal health coverage. And, you know, if we go back to the SDGs, there are global health mandates that include the workforce. So one of them is to increase the financing and recruitment and development and training and retention of the workforce in developing countries, and also the workforce global milestone of 2030, which I want to remind the people of, which is all countries are making progress towards halving inequalities in access to a health worker. So in other words, what we are trying to do is to, instead of using the language of shortage, because every time people, oh, there's shortage, we know there's shortage, but we want to put that situated in the language of equity, which means we want equitable access to health workers, not just to medicines and you know, machines and surgeries and all of that. And so this milestone is we need to halve the inequalities, so cut by half in 2030. So we have a lot of work that needs to be done. And why health professionals are very important? Because they offer the human link to translate the knowledge related global public goods to the requirement of local realities. And they not only they translate, but they also produce knowledge. They are leaders, they are planners, and the implementers in the health system. And globally, even in high-income countries, when we talk about the critical shortages, we could talk about chronic underinvestment from all entities, government, institutions. There's an inadequate skill mix that when we in the workforce that produce and even geographical distribution. This will result in inefficiencies in the health system, inequities, and lack of support and protection for the workforce. And so if we look at in terms of just numbers, we see here in Nigeria has 70 clinical oncologists as very recently to serve 213 million total population. On the other hand, from a survey in 2018, the United States has approximately 161 oncologists per 1 million. So you can see the stark disparity in 70 to serve to 113, and you have million, and you have 161 to serve 1 million. In terms of the workload, we know that we together with my colleagues, Dr. Van der Poel and others, we published part of a global survey. We published the African part of it, and we know the proportion of oncologists seeing more than 500 consults per year was 31% in Africa compared to 12% in other countries. And the median number of annual consults, which consult mean new patients per oncologist in Africa, were 325 compared to 175 in other countries. So you can see this is really a huge disparity and significant workload. And then when it comes to how we produce the workforce itself, the training. So if I look at, we conducted a survey that we published in 2020, looking at training of oncologists globally. We looked at several aspects. So we had 300 oncologists reply, some of them from Africa, some from Latin America. And we just asked a simple question: did you self-fund your training when, or the government or other entities paid for you? And we found that 37% of respondents from low and middle income countries were self-funded compared to 11% from HIC. And that's a huge equity issue, because then you'll tend to skew recruitment of trainees from those who are able to pay, and most people will not be going into rural communities or smaller communities and will be more urban. And so after COVID-19, a lot of the African institutions have seen some decreased funding for training positions, and a lot of the trainees are struggling during their training because they need to have salaries and all of the other, costs of living. Despite all of this, I would say in the last 10, 15 years, there has been significant progress in Africa when it comes to the workforce. And so, and these, we can look them as macro trends. So the picture is not that big. So what we're seeing now is more training programs. Every day there is a new training program starting somewhere. So we know, for example, the recent medical college training program in Rwanda, the one in Kenya that started in 2016, this started last year. We have stronger professional accrediting bodies. So WACS, there was the African College of Surgeons, and COSEXA, and the East Central College for Oncology that just started, and South College of Oncology that started a few years ago, are becoming more interested in oncology. And then we have a very interesting phenomena, which is the emergence of national societies as a strong advocates for training and for the workforce, such as KESHO, Kenyan Society for Hematology and Oncology, ESHO, which is the Ethiopian one, ECON, which is the Nigerian one. And we are witnessing increasing connectivity to the world, and we are seeing emergence of a very strong young cadre that we are really proud of, and we are thinking over the next years they'll make a lot of changes. We're also seeing increase in the number of cancer care facilities and increase in the research output, including research on the workforce dynamic, as I will show you throughout this. So this is from the Ethiopian Society of Hematology Oncology meeting in 2024. All of these, most of them, as you can see, lots of young folks, very dynamic and motivated. This is from the faculty development workshop that we conducted in Kisumu in Kenya in 2024. A lot of young oncologists and pharmacists and nurses have attended. And if we look, and I talked a little bit about physicians, I guess because I'm a physician, but also if we look at the situation of nursing, this was published in 2021, Strengthening Oncology Nursing Education in the Year of the Nurse and Midwife. I had the pleasure of working with my other colleagues who are also nurses. And you can see there are lots of training programs for oncology nursing in many of these countries. There are some countries that don't have, but the situation is improving. So I move to the next part, which is what are the challenges and threats to optimization of the cancer workforce? Some of these we see a lot in Africa, but also even in some high-income countries, we see that. So the issue of the supply, we talked about the training, the education, the cost, and the shortage of the teaching faculty. And then there is the issue of employment. So what we see is sometimes a paradox is that there is a shortage, but then once you have trained oncologists or nurses or other, sometimes they don't get employment opportunities because the government doesn't open jobs. And so you have the on this part, on this side there's a huge need. On the other side, some people are not getting employment. And then the underdeployment is when you don't have the right person for the right job in the right place. And we see that a lot with oncology nursing. Sometimes the nurses put themselves through the training, a lot of struggle, and then once they go to the healthcare facilities, sometimes they are pulled to do ICU work. They are pulled because a lot of the time oncology is not seen as that important. And of course, the issue of low wages. We talked about distribution and even distribution geographically and even within institutions, diversity in the sense of gender inequality, ethnic inequality in some parts of Africa where some groups don't have access to the training like other groups. And then unregulated private sector and dual practice, we're seeing a lot of private facilities, which is great because they increase access, and dual practice when people practice in both the public and the private centers. However, there are issues related to it. Some of it is internal brain drain from public institution, and then it also affects access to care because some of it is inequitable. And then the effect on cancer research and cancer registry. Some of these patients may not be put into the cancer registries. And so we miss a lot of data. And then there are other ongoing threats, migration, burnout. In last Awartic, we talked about, we had the session actually called Burnout Among African Oncologists. Does it happen to us? Which was very informative. We have a survey that's now ongoing, meager professional development opportunities, which lead to lack of intellectual stimulation. And then, of course, we have the workforce issues because of in conflict area because of displacement. So what are the strategies that we need to optimize the workforce? So hot out of the press is our chapter in the UICC book, Cancer Systems and Control for Health Professionals. And you can see together with my other colleagues, most of them are from Africa, Dr. Abdelhamid, Haimonot from Ethiopia, Dr. Van der Poy. And so we talked about 5 strategies. I encourage you to read those in details. One of them is related to the supply, which is increased quantity, improved quality, and boost relevance of cancer workforce through transformational upscaling of health professionals. And these several details, including competency-based education, defining the competencies, enhance investment and funding of training programs, infrastructure and institution, and support the faculty and trainees, harness the power of online learning, align accreditation to global standards, strengthen interprofessional education, which is very important to stop professional silos and strengthen the research and cultural evaluation and critical inquiry in cancer workforce education and training. We have to address the maldistribution and improve retention, particularly in underserved areas, competitive salaries, compensation, then financial incentive like professional development, address the paradox that we talked about of shortage and underemployment, and underdeployment, protect the health workforce, including women and youth, the gender pay gap, working condition, and poor recognition, an unfair mechanism of promotion, along with overload and discrimination and harassment. We are also the push and pull factor in migration or brain drain. The push factors is low wages and other poor working condition, and also the pull factors that high-income countries need to train their own force and observe the WHO Global Code on International Recruitment. And again, we need to incorporate a safe task sharing that has to be, and adequate supportive supervision. So we don't just say task sharing and shifting, and we don't follow it with the supportive supervision needed. And so and then workforce in conflict area and natural disaster zones, we need to support them and support modeling and forecasting. And that's when you have that data actually can help you to forecast what are your needs and to model. We need to improve diversity of cancer workforce registries, pipelines and programs to bring people from rural areas from low socioeconomic status and have them access training programs and implement gender equity. So one of our abortic contribution was this task force, challenges faced by women oncologists in Africa. The findings were just published last year in BMJ Oncology. So there was a Delphi process. So as you can see, the challenges based on a score for work-family balance, lack of support and networks, microaggression, lack of mentors, access to support staff, and operating time, leadership, being perceived as less competent. So there we are. I'm proud to say that the workforce in Africa are looking and producing research looking at what is going to work for them. So one of the recommendations to be accountable to women. So this is some of the courts, like institutions should be held accountable for how women are doing, and also the work-life balance, maternity and paternity leaves, and all of that. So I encourage you to read all of those for the nurses and in education in Africa, looking at the challenge. That's from the paper that was published in eCancer. Challenges in leadership, in educational pathway and research, including lack of nursing leadership, lack of funding for oncology nursing program, dominance of the medical profession at the expense of the occupational segregation and professional silos. And there are lots of recommendations for how to address this. Then the last strategy is to establish workforce registries. Just like you establish cancer registers, this is actually one of the recommendations from the WHO and to what we call Work Information System, WIS, because it helps you. So you look at how many enter the workforce, how many are you training, how many are retiring, and then you can forecast, you can model, and help you to invest and help you to allocate adequate resources so that you can produce a workforce that you need. And so this is from one of the publications we had on what it can do. So we looked at several workforce information systems. So this is the one that ASCO has, and it can tell you the rate of increase in the number of oncologists is higher compared to other physicians. However, there's a lot of physicians who are retiring. It tells you like the Black oncologists in the US are only 3%. So there is a shortage. So it gives you a picture of what's going on so you can address it. Now that we talked about these strategies, how do we implement them? How do we mobilize? How do we talk to stakeholders such as the Ministry of Health, the Ministry of Education, our politician, and to the public to invest in the cancer workforce. So I would use in the 2023, the WHO came out with 3 key areas for action, which called the workforce action triad, which is protect, invest, and together. And this is in response to the challenges related to after the COVID-19 and during the COVID-19 pandemic. So I will start with invest. And why start? Because in the current macroeconomic context, there are a lot of countries and people are seeing decline in their economic conditions. So we need to really fight hard for cancer workforce. Investing in the cancer workforce will generate actually socioeconomic dividends. And when we invest in education and employment, we need to see that as a priority because they're under a lot of threats. So the premise is that cancer is a major health threat in Africa. And the cancer workforce will make invaluable contribution to the economy, to decent employment, to gender rights, given that a majority of the workforce is composed of women, and societal health and well-being and health security. And if we look at the economic aspect of it, we know that cancer care is very expensive and we are losing money. So this is a photo from The Guardian in 2021, when I think this was the president of Nigeria came to the UK for his cancer treatment. And there was an outcry because Nigeria is producing brilliant, workers and doctors. And the gist is that Nigeria spends 1 billion annually on medical tourism, with 60% in 4 key specialties. Number 1 is oncology. So we're actually losing a lot of money. And so we studied this, and I encourage you to read this paper with medical tourism, which was just published in JCO Global Oncology. We looked at people leaving Africa to get medical tourism, or sometimes within Africa. And the most common reason for the going out is perception of higher quality of care in foreign institutions. We have other findings, but these findings led us to suggest that we need to improve the local health system and build trust. And because of the potential financial toxicity, there has to be emphasis on return of investment on homegrown workforce. So if we don't improve our workforce, we will continue to lose money. And so how do we get there? We need to prioritize healthcare and workforce investment. We need to produce data on the workforce. We need to concentrate on workforce leadership and advocacy skills. So not just how do you treat breast cancer, but how do you advocate to get resources for breast cancer. And we need to generate quantifiable evidence that spending on cancer care and workforce saves money and generates money and other societal benefits. Well, one of the things that came from the COVID-19 lessons is the concept we need oversupply of the workforce, because some people say, oh, we have enough nurses now, we have enough doctors. Actually, because of the threats and the crises, so this is me in our home in Khartoum, and this is during my mother's funeral. Everyone came together to work, and so there's always this is an African concept. Everyone comes to share in the work. Sometimes you have others who are standing by to help, but also so we have this concept is truly African. We need to keep it going. And during crises, the workforce will step up. So Sudan has implemented local training for oncologists. And when the conflict happened, because we had a better workforce and a lot of the surrounding countries, despite the challenges, there was still cancer care in Sudan. And so we should never say we have too many nurses or oncologists or radiation therapists or pharmacists. The last few slides protect the workforce. And other than investing, we need to train, we need to give decent salaries and working conditions, gender responsive workforce policies, safe working condition, and we need in the order that we need solidarity. So together means the solidarity. We need to come for the last pillar. So we said invest, protect, and together in regional and continental solution, public funding for cancer workforce education, so that the trainees don't have to pay out of pocket. We need supporting training programs and academic institutions. And we ask high-income countries to invest in training their own workforce so we can stop this pull factor. Now, this is my last slide. So our workforce wish for 2030 is we need to come together as aortic and other organization, and as a continent with more robust strategies and ability to mobilize and support the cancer workforce and cancer patients in Africa. And I hope to see many of you in Tunisia for the conference this year. Thank you so much.
Excellent. Thank you so much, Nazik. That was fantastic. And that was very robust and lots of information there. So thank you all for listening. So please go ahead and hold on to questions that you have for Nazik. And You can put them in the chat now or just hold on to them, write them down to yourself. We will have a full opportunity for discussion after we listen to our next speaker, who I've already introduced, Dr. Kudzai Makova from Zimbabwe. So please, Dr. Makova, over to you. We are perfect. Okay, now we're seeing your screen. If you want to put it into, yep, it's perfect now. Excellent. Over to you, Dr. Kudzai.
Looks like I was muted. Let me share my screen again.
Okay, great.
I hope you can see my screen and you can hear me loud and clear.
Yes, perfect.
Thank you very much for the kind introduction, Mishka. I'll be taking you through Zimbabwe workforce needs for cancer for our NCCP implementation, strengthening the cancer workforce in Africa, the Zimbabwean perspective. The session objectives have already been shared, and this is the outline of my presentation. So Zimbabwe is a sub-Saharan African country within the SADC region. We have a population of about 15 million people. The male and female population is almost equal, with slightly more women. We have a rising cancer burden, with over 7,500 new cases of cancer being diagnosed from our cancer registry report, but it is actually projected that we have many more cases of cancer because of limitations in diagnostic services, particularly pathology and radiology services. We have 3 cancer treatment centers in Zimbabwe. These are between the 2 major cities, Harare, which is in the northern part of the country, and Bulawayo, which is in the southwestern part of the country and the second largest city. Cancer workforce remains lean in spite of the rising demand of cancer services and the increasing cancer burden. So the role of our cancer workforce in our NCCP implementation efforts spans the pillars of cancer control, from cancer prevention, where healthcare professionals have the duty of educating our communities on risk factors, risk reduction interventions, signs and symptoms of cancer, and the available screening programs, particularly for the common cancers we see in Zimbabwe, cervical and prostate cancer. And our oncology and palliative care nurses and government medical officers in the district hospitals play an incredible role in this effort. Early detection, which entails screening and early diagnosis, is one of the critical pillars of cancer control in Zimbabwe, and appropriate referrals to higher levels of care are made, and the same cadres I've mentioned play a critical role. The diagnosis of cancer remains integral in the cancer treatment cascade, where we need a tissue diagnosis for us to be able to treat patients. And this is one of the limitations when pathology and radiology services remain centralized. Cancer treatment services are also largely centralized, but we now have a decentralization effort in progress, and patients have access to surgery, chemotherapy, radiation therapy, and novel therapies. Palliative care and support services are part of the continuum of our cancer care services, from diagnosis up to the end of life. And at the lower levels of care, we have our oncology and palliative care nurses playing an integral role. And research is really critical to inform policies and evidence-based interventions. I think it's important for me to take you through the levels of our healthcare system in Zimbabwe, starting at the primary care level, where cancer services are actually available from screening. This was largely a VIAC-based program, but lately we have now introduced HPV DNA testing as one of the pillars of primary prevention of cervical cancer in Zimbabwe. And across the continuum of care, you see there is increase in complexity of available services and expertise available for care. But I wish to bring to your attention this very exciting development of a quinary hospital, which is under construction under the auspices of the University of Zimbabwe in collaboration with the Ministry of Health and Child Care, which will be a center of excellence with oncology, one of the critical areas where equipment will be procured to ensure that we're able to offer world-class cancer services to our patients. And this will also be a boost to the already existing healthcare infrastructure which is in place. Our NCCP framework for the cancer workforce aims to increase the number of competent personnel throughout the continuum of cancer care, right from prevention up to palliative care by the year 2030, with a main objective of addressing the numerical gaps in human resources to ensure we have an adequate establishment in our centers of well-trained healthcare personnel across all the specialties of cancer care, from diagnostic radiography to therapy radiography, medical physicists, surgical oncologists, oncology pharmacists, and palliative care nurses. And this is implemented through the partnerships between our Ministry of Health and Child Care, as well as the Ministry of Higher and Tertiary Education, with support from the international partners. I think this slide really brings into perspective this discussion we are having on the importance of the workforce, highlighting workforce gaps in Zimbabwe across the critical specialties. From the first presentation, it was noted that in Nigeria, there are 70 oncologists for a population of over 200 million. In Zimbabwe, our situation is a little better. We have 15 clinical oncologists for a population of 15 million. But for the commonest cancer we see, which is cervical cancer, you see we only have 2 gynecologists who have done subspecialty training in gynecological oncology and would need at least 10 to be in each province, at least having 1 gyne-oncologist in each province. And we realize that some of the challenges we encounter in clinical oncology is patients who are undergoing suboptimal surgery, which compromises oncological outcomes. Surgical oncologists, we have 2 who have completed their training, and these are trained in breast cancer oncology. One is based in the northern part of the country, the other in the southern part of the country. But you'd see that the gaps are very, very significant. If you look, I did mention that diagnostic pathology is one of the integral specialties for us to be able to actually get that tissue diagnosis to enable us to implement cancer care. We only have 10 pathologists with an ideal number of 64, a gap of you see that a huge gap to be filled. Diagnostic radiology, a very important specialty for us to be able to adequately stage our cancer patients. We have 17 with an ideal number of 64. So as you can see, there is no single specialty where we can say we have an adequate workforce in place. So the Ministry of Health in Zimbabwe has a very important role in closing these workforce gaps. Our NCD department, which oversees cancer control services in Zimbabwe, has an existing policy framework which supports manpower development for the cancer workforce, that is medical and nursing practitioners who wish to advance their studies in oncology and palliative care nurses, radiation oncology, and other oncology specialties. There are also presidential, there is a presidential scholarship program which supports training, particularly for specialties that are not locally trained. There is need for a needs assessment to identify the important gaps I did mention the gaps in pathology, the gaps in medical physics, as we, in the past decade, medical physics training was actually not available in Zimbabwe, but the main or leading university of Zimbabwe, the National University of Science and Technology in the southern part of the country, have recently introduced training for medical physics, support for the local training programs. We have a radiation oncology training program from the early 90s, excuse me, which was initially supported by an effort supported by the World Health Organization. And to date, there are over 27 oncologists who have been trained in Zimbabwe. Some are now based in countries in the region, Botswana, Malawi, Kenya, Canada as well. We have an oncologist trained in Zimbabwe practicing there, and a colleague with the IAEA in Austria, which speaks to the quality of our training. The need for capacity building to improve our infrastructure, to ensure that we have adequate services. I did mention the construction of the Queenary Hospital, which will aim to be a center of excellence across the continuum of oncology specialties. Partnerships are very integral in making all these things a reality, collaborating with both local and international partners. The technical expertise we get from them is particularly important. Monitoring and evaluation, a very critical component of seeing where we are and ensuring that our training programs are responsive to our national needs, and we have a body that monitors the quality of our training curricula. Zimbabwe has lately adopted Education 5.0, which is an innovation which drives industrialization and economic growth through this new approach to tertiary education. And it is cross-cutting across the different fields of training, from medicine, science, technology, agriculture, and other disciplines, where the key components of this approach include innovation, which encourages creative solutions and new ideas to address healthcare challenges we are facing, in particular cancer treatment, industrialization, to foster partnerships between the academia and industry, to develop new technologies and products, potentially improving cancer diagnosis and treatment using innovations like artificial intelligence, the importance of teaching, which helps to develop a skilled healthcare workforce with expertise in cancer care, the importance of research, conducting local studies to ensure that we have got local evidence that will enable us to have guidelines that are tailored to our population, and the importance of community service, which engages healthcare professionals in outreach programs, promoting cancer awareness and prevention efforts. There are multiple benefits of the Education 5.0 initiative, which would include improved cancer care with a focus on innovation and industrialization, which can lead to new technologies and treatments, improved skills of our healthcare professionals, with an emphasis on teaching and local research. And this can develop our workforce with expertise in cancer care, addressing the shortages that exist, and with the overall goal of improving oncological outcomes. Enhanced collaboration, partnerships between the academia, industry, policymakers, which can facilitate knowledge sharing, resource allocation, and effective, cost-effective cancer control strategies. But with every or any innovation, there are challenges that can be expected. Education 5.0 requires significant funding, and limited funding from a central government can hinder implementation efforts. Resistance to change from previous curricula may also be a challenge, and also policy consistency may be an issue, but this is a work in progress, and we are beginning to see the results of Education 5.0. In terms of improving the skills of our cancer workforce in Zimbabwe, we are part of collaborations within not only the SADC region, but the greater African continent. Zimbabwe is a regular participant of the Access to Care project in Cape Town, which is run under Crucis Care Hospital, a training program designed to equip African radiotherapy professionals with practical skills, particularly with advanced radiotherapy techniques, as we advance from 3D conformal radiotherapy to more conformal techniques. We get support from our partners in the South, and these training programs target radiation oncologists, medical physicists, and radiotherapy technologists. We are also part of the Society for Neuro-Oncology for Sub-Saharan Africa, SINOSA, a body with an overall objective of improving outcomes for childhood and adult brain tumors. And Zimbabwe was the proud host of the 2024 SINOSA Continental Conference, which was an important opportunity for colleagues within the region to exchange information and experiences on how we can improve outcomes for brain tumor patients with the limited resources and experience that most colleagues working on the African continent are familiar with. And members of our oncology profession are part of IOTIC, which is an organization which aims to address the challenges of cancer in Africa through various initiatives like research, the support for training, raising public awareness on cancer, and supporting residents in training with scholarships to attend conferences, presenting abstracts, and fostering the spirit of research. The European Society for Medical Oncology has an African summit, which is held every February. And it's also an opportunity for oncology professionals to be educated about the advancements in cancer therapies and research activities on the continent. These are images of the SINOSA conference, which was held in Harare, Zimbabwe. It was a very successful conference, and you see smiles. There was lots of food and drink, and it was a very, it's something that we are very proud of. I'll speak a bit about subspecialty training in oncology. I did mention initially that gynae-oncology remains a very essential specialty, as we are a high burden, we have a high burden of cervical cancer, to ensure that effective surgery is performed for these patients. But we do note that there are limited resources and the need for specialized care is ever so increasing. Subspecialty training allows for more targeted and effective approaches to cancer treatment, improving patient outcomes and survival outcomes. This training helps to address the gap in cancer management by equipping oncologists with the necessary skills to handle the different types of cancer, ensuring comprehensive multidisciplinary approach. The African Pediatric Fellowship Program has seen the training of literally all our pediatric oncologists, the 4 of them. And fellowship programs have a very important role in upskilling our workforce in response to the demands for newer technologies and international best practices. One of the cornerstones of improving patient outcomes is the multidisciplinary management of cancer, which remains the gold standard of cancer care. And this speaks to the importance of how a boosted cancer workforce would result in all these multidisciplinary teams working very effectively. The gynae-oncology MDT, which is held fortnightly, is one where we discuss our gynae cases, including cervical cancer cases. We have a breast oncology MDT, and all these others I listed, including our participation in AfroNet and our ICCP ECHO participation for NCCP implementation efforts. And one which I'm proud to share is the lung cancer MDT, which is a multinational lung cancer control project involving a number of countries: Eswatini, Ethiopia, Lesotho, Tanzania, Kenya, South Africa, and recently Zimbabwe. And it was inspired by the work of one of our colleagues, Dr. Majindu, whose dissertation on lung cancer really set this proposal on pace, and we are very happy to be part of this initiative. And one of the goals of the initiative is to also support the training of health professionals with an interest in lung cancer research. Digital health and telemedicine. COVID-19 played a significant role in advancing telemedicine in Zimbabwe, as most of our correspondence became virtual. But there's need for appropriate instruments by our regulatory body, the Medical and Dental Practitioners Council of Zimbabwe, to ensure that this can be implemented in a way that ensures that we still get quality and healthcare workers are adequately trained. There are opportunities for learning through international tumor boards, and there's also an enormous potential for growth once the legal instruments are in place. And this will enhance the decentralization of training for oncology specialists. There are a number of challenges and opportunities when it comes to addressing our workforce challenges. Lately, we had a challenge of brain drain. This was compounded by a prolonged radiotherapy machine breakdown just after the end of the COVID pandemic. But it is good to report that our machines are back online, and there are a number of initiatives to procure more machines, and the Queenary Hospital project I have spoken about. There are a lot of opportunities for training of cancer workforce. This has been decentralized to a number of universities. Traditionally, the University of Zimbabwe was the only university that was offering training for medical programs, but other universities like the National University of Science and Technology, the Midland State University, and the Great Zimbabwe University are also on board in the training of healthcare professionals, particularly in medical physics and radiotherapy, therapeutic radiography. Thank you very much for your attention. That's my last slide.
Thank you so much, Kadzai. That was excellent. And again, another very robust presentation. So thank you to you both, our amazing speakers, for your presentations. We now are very happy to open this up for discussion. I first want to acknowledge many of you who have joined have gratefully shared your names in the chat and introduced yourselves. If you haven't done so, please go ahead and do so. I have noted that we have a good representation, and I'm glad you mentioned on childhood cancer as well, Kadzai. We do have representation from pediatric oncology here. I do see folks in the nursing field. I see a good number of folks with people with lived experience who are advocates and working in support of cancer patients and people post-treatment as well as palliative care and cancer planners, folks working at the local region. We have clinical officers. Anyway, we have a whole group of very diverse individuals here, and happy to see you all. There's already been some robust discussion in the chat. So I saw that Elizabeth, you had asked Nazik the question around opportunities. If somebody is not a medical student, I welcome you all to take a look at the chat as well, as Nazik did answer there. And then Priska, you also asked a good question on strategies for strengthening the workforce, which is basically the whole discussion here. So Nazik, I'm glad you were able to share in the chat the link to the UICC book on cancer control that addresses the strategies for strengthening the workforce. So I don't know if Elizabeth or Priska, you wanted to come off mute to ask further questions. And then otherwise, I'll open up the floor to others to ask questions. I see Venus, you have your hand up. Please go ahead and introduce yourself first for, of course, I know you, Venus, but of others who do not.
All right. Thank you, everyone. Thank you for the wonderful presentations. And I think I'm glad to see there's a lot happening in terms of building capacity for oncology workforce. I have a few cross-cutting questions. I just want to ask both presenters if maybe you can highlight, because I'm looking at the teams. It looks like the training is still limited. The multidisciplinary team training is not coming out. I wanted to find out from your settings if there are any interventions that are going on to expand that training to, for example, pharmacists, ophthalmologists, psycho-oncologists, and all that, because it looks like from that our training is mostly skewed towards the nursing and the medical and the radiation therapy, but looking at the concept of holistic care for the patient. Maybe if you can comment to that. And I also just wanted to check in terms of training of healthcare professionals. I wanted to find out if the training curricula for all health disciplines, if there's been moved to make sure that there are modules on oncology, because I think that's a low-hanging fruit where we can have at least some introduction, pre-service training to oncology. And also, I wanted to check on the post-service training programs, mentorship programs. Is it something that is available in your settings? I think, yeah, those are my questions for now. Thank you.
Great. Thank you, Venus. Kudzai, do you want to go first? And then Nazik, you can follow.
Thank you very much, Venus. Very pertinent questions. I think I'll address your first question on MDT care, how it's imperative to have holistic care for patients, and how sometimes the MDTs may not be complete without inclusion of other specialties like pharmacists, rehabilitation personnel. From my experience, MDTs are relatively new in many ways, in the sense that the management of cancer patients used to be disjointed in the past. The patient is seen by a surgeon, and then they have suboptimal surgery by the time they are referred to oncology. But the establishment of these multidisciplinary teams has raised awareness, particularly among surgical specialties, to first consult to get an oncology opinion before operating on a patient. For the multidisciplinary teams which I highlighted, the management is individualized for each patient, and for a patient who may require the input of a particular specialty, definitely we have those specialists on board. And then on the training of healthcare professionals, one of the major challenges that we had in Zimbabwe was this was highly centralized to Harare, the University of Zimbabwe, or Pararenyatwa group of hospitals. But the move to decentralize training and to decentralize care to the provincial hospitals, to other universities, has created opportunities to expand our cancer workforce. Then the last question on pre-service training and curriculum strengthening. That's something that is actually in progress at the University of Zimbabwe. I did speak to Education 5.0, how there's been a revolution to how the training of doctors is now being conducted. Instead of the traditional MBCHB program, there is now like a pre-med course before they then move on to the clinical rotations. And oncology is one of the modules, and the Department of Oncology from the University of Zimbabwe actually has the mandate to administer that training. And with the improving literacy of oncology as part of our the nursing curriculum, also includes training for oncology, as there is also a specialist training program for oncology and palliative care nurses.
Thank you, Kudzai. Nazik?
Thanks. Can you hear me? I had to put some headphones because there'll be some noise, a fire alarm going soon. Okay, so I think that's an excellent question. First of all, we need to start, I'm glad to see the efforts in Zimbabwe. We need to start with the concept that the patient needs this holistic approach. And so if we change the culture and the way we deliver care, that the patient needs psycho-oncologists, the patient, psycho-oncology, the patient needs social workers, and patient navigator. And then so we start with awareness about the importance of these professions. And then we integrate them in the, in the team, in most of our settings. That will be a next step. And then, of course, and that will also answer some of Salome's question, is that this kind of dashboard, we need actually this kind of workforce registry or dashboard that will tell us how many nurses we have, how many doctors we have, how many pharmacists in oncology we have, how many social workers. And so that will be comprehensive. So we don't have gaps here and no gaps here. Even like radiation therapists, there are some programs in Ethiopia, for example, they wanted to start in Harar, radiotherapy, and they couldn't find radiation therapists, although there were doctors. So I think that that kind of planning, which is called work, we need to have a central workforce planning that could be part of the NCCP. Unfortunately, sometimes the NCCP will concentrate only on nurses or something, but so we can tailor our own NCCPs to include these professions, and they need to have their place. And for example, oncology pharmacists, the chemotherapy and all the drugs